Hey, welcome to the this new question and new explanation of previous year question. And I am the bogus doc and welcome here. So we will read about Gitelman syndrome today, Liddle syndrome today, and two more syndrome and some relation from here and there. Okay, this is a great session and I hope you will love all the concept and it will solve all the question you have. Okay, so let's start with Gitelman syndrome. Okay, as I told you, Gitelman syndrome, it is a resemble with thiazide. Okay, you have to remember that Gitelman syndrome and Barter syndrome both are autosomal recessive. Okay, by the thiazide, you can remember the thiazide action by the two thing, the word two, T for thiazide, T for two, and there is the NaCl, it means two channel sodium and chloride action on the two channel, and it does two things, two hyper thing and two hypo, two hyperuricemia and hypercalcemia, and it does two hypo, it does hyponatremia and hypokalemia. Okay, the resorption defect of NaCl. So, okay, where all it start in the DCT, in the distal connecting tubule, there is a channel, NaCl channel, or we told it NCC. Okay, sodium chloride channel. Okay, this says ki go Simon go. Actually, this is saying ki no, we will not absorb neither the sodium and nor the chloride. Okay, both the ion will not absorb. Okay, now this we will say ki there is no electrochemical gradient in this, okay, inside the cell, and as there is no electrochemical gradient to or no driving force for the magnesium absorption, okay, no magnesium absorption driving force, so there will be loss of magnesium, so magnesium will be lost in the cell. Okay, so if you say hypomagnesemia will be there, as magnesium is essential for PTS secretion. PTS secretion के लिए magnesium is essential, तो decrease PTS release, and if the PTS release, it decrease calcium transitionally or functionally because of low ionized calcium. But if you read some books, there is written that serum calcium is normal, but because calcium is transiently or functionally decrease. Remember this, and that's why the hypocalcemic sign like tetany or Chauvistok sign is present in this question or in this patient, in these patient. Okay, if you see as sodium chloride is uh, excreting out, lost in urine with water, there will be osmotic diuresis. Matlab means if the sodium chloride is losing, there will be water along with, that is known as osmosis, osmotic diuresis, and by this the patient will increase with thirst because of he or she is losing water. There will be increase in thirst. There will be nocturia, again and again going to pee. There will be polyuria and polydipsia. Okay, polydipsia means increase in thirst. Okay. If you see by here, as sodium chloride is losing, the body will try to compensate by increasing as salt and waste is losing, decrease volume, and the RAS will be activated, and we will increase with aldosterone. So aldosterone will save sodium at any cost. Okay, so sodium is absorbed in the exchange of potassium and hydrogen. Okay, so in the end, the potassium will be lost, and this will cause hypokalemia, and H plus is lost. This will cause metabolic alkalosis, and in favor metabolic alkalosis also cause hypokalemia. So actually potassium is essential for the normal muscle cell function, so that the patient will present with fatigue, cramps and muscle ache. So there will be fatigue, cramps and muscle ache, and there will be osmotic diuresis, thirst, nocturia, polyuria, polydipsia. So this patient will present with these symptoms. Okay. So in Gitelman syndrome, there will be NCC defect. By this, there is no electrochemical gradient in the cell, and TRPM6 is not work. That's why magnesium will rise. The PTS role will come here. Osmotic diuresis role will cause thirst and nocturia and polyuria. The aldosterone will ultimately cause metabolic alkalosis and hypokalemia. If we go to the second disease, the Barter syndrome, Barter means loop diuretic. Okay. We can remember by the trick bartender that I posted yesterday in my group. Bartender loops around the girls. Remember by this, bartender works like, bartender means Barter syndrome act on loops, like work like loop diuretic. Okay, that Gitelman works like thiazide diuretic. Okay, but the Barter will act like loop diuretic. Okay, and you can remember this trick further, loops around girls and lose cash. Okay, and lose cash. Okay, lose cash means it loses the magnesium and calcium here. Okay, so what is happening here, it act on the thick ascending loop of Henle. Okay, thick ascending loop of Henle. There is a channel sodium potassium 2Cl. Okay, sodium potassium 2 chloride channel, that is NaK2Cl channel, that is work here, and the defective in this channel. Okay, the defective in this channel, the calcium and magnesium is also lost here. You see that. So if you read the pathophysiology, you will see that this sodium potassium 2 chloride not absorbing the cage potassium, as sodium potassium chloride is absorbed, but the potassium is limited channel. Okay, potassium is limited ion here. Okay, so for the reabsorb sodium and chloride again, the potassium will come out of ROMK channel. Okay, as potassium limited. So potassium should come back to operate this transporter. Okay, in this thing, as sodium is come out, there will be positive ion outside, and there will be paracellular effect or paracellular moving of calcium and magnesium. Okay, as I read in some books that this is the it's not like if it's not here like positive sign attract negative sign. Here it is like the that positive sign is giving away the positive sign, or doing pressure to push positive inside by the paracellular space between the two cell, and the calcium and magnesium move inside. So if this sodium potassium 2Cl is not working, the paracellular effect will be not there, and the calcium and magnesium will also lose. So there, that's why there is a calcium magnesium also lost. Okay, so it in the this is a thick ascending loop of Henle. Okay, so distal tubule will compensate as I told you by the increasing aldosterone and renin, and there will be same like hypokalemia, metabolic alkalosis, and I told you about the hypercalciuria. Okay, so Barter will be easier if you again want to know that there will be potassium is the limited iron here. Uh, as potassium will lose, there will be outer positive side, and outer positive side will push the same positive side ion in this inside the cell from the lumen. Okay, to it's like the pole, north pole is एक दूसरे को दूर भगा रहे हैं इन सिंपल, एक दूसरे से अपार्ट कर रहे हैं एक दूसरे को, एंड द सेफ स्पेस फ्रॉम द lumen is the intercellular space and inside the cell and in the blood. Okay, the next thing is Fanconi syndrome, and it is the end of PCT. Fanconi means you can remember finishes PCT, means a generalized reabsorption defect in PCT, and the important thing is phosphaturia. Okay, or the blood will find hypophosphatemia, and as there is amino acid will not absorb amino aciduria, phosphate and bone disease as calcium is not absorbing, phosphate is not absorbed. Renal tubular acidosis, because acidosis is a common finding because bicarbonate is not absorbed by the PCT. Sodium and water wasting, polyuria, polydipsia, because sodium and potassium is going out, proteinuria, calciuria. This is all we will found. Okay, Fanconi means all the defective in the PCT. Okay, it finishes PTC simple, finishes PCT simple. Remember by Fanconi. And let's move to Liddle syndrome. Okay, in the Liddle syndrome, if you see, this is something important. You will, it is the autosomal dominant, Barter, autosomal recessive, uh, thiazide wala Gitelman is also autosomal recessive, but Liddle is autosomal dominant. Okay, it is a gain of function mutation, mean INICET channel will overactive. This will function overactive. Sodium will save, and along with sodium, water will also save, and to compensate, potassium and hydrogen will lose. Okay, how this will lose, because as potassium is going in, there will negative charge outside the cell membrane, outside the lumen, and to cover that negative charge, the potassium and hydrogen will come outside. Okay, so hydrogen and potassium will lose. Okay, so here like the metabolic alkalosis, because potassium is hydrogen is losing, hypokalemia because potassium is losing, and metabolic alkalosis. I did try it 2 times. Okay, done. And as sodium in water is coming inside, okay, so there will be hypertension, and hypertension will give negative feedback to RAS, and the renal will be decreased. Okay, and the aldosterone will be decreased because the body is full of already of sodium and fluid. Okay, this is known as pseudo aldosteronism, because there will be hypertension like hypertension, hypokalemia, metabolic alkalosis like picture. Okay, the drug of choice that inhibit the INEX channel is the amiloride. Okay, you will remember the Conn syndrome, that it also confused. It is also have has hypertension, hypernatremia, hypokalemia, all three things, and you can remember by this. C for potassium, potassium and N means sodium, sodium is more. Okay, there will be hyponatremia and hypokalemia. Because this is like there is a adrenal tumor in this, the more aldosterone will be there and it will save sodium water. But as aldosterone is more, there will be no role of which hormone? Renin. So renin will be low in Liddle also, and renin will be low in Conn syndrome also. And this aldosterone will also lose K plus ion. Okay, so I hope these all chapter, all four concept, five, Liddle, Barter, Conn syndrome, hyperaldosteronism also known as Fanconi, and actually Liddle. Okay, uh, this is Gitelman. These all five are finished, and the drug of choice for the Conn syndrome is spironolactone. I hope you love this chapter. There will be some fumbling of words. I hope you will adjust it. Okay, thank you. Keep following and share to your friends.